All right, so we're going to talk about upper tract urothelial carcinoma. So it can be a really tough disease to manage. So I see a lot of it being referred to a lot of these patients. Happy to see them. But it really comes down to an informed discussion between the patients on how you can help these patients. So just real quick, it's a rare disease, 7,000 cases per year. Smokers are at a higher risk over non-smokers. 60% are invasive at presentation. The peak age is in the 70s, 80s. As you can tell, most of urothelial carcinoma is in the bladder, with 5 to 10% being in the upper tracts, mostly in the kidney, with a third being in the ureters. Luckily, we have algorithms that show that can risk stratify upper tract urothelial carcinoma. So low-risk patients are unifocal disease, tumor size less than 2 centimeters, negative for high-grade cytology, low-grade ureteroscopic biopsy, and no invasive aspect on CT. If you see on CT that it's just looks really infiltrative, there's a lot of stranding around the kidney, that should set off some red flags. This is more than you want to deal with. In that case, radical nephroureterectomy is very rarely the wrong answer. So why are we talking about endoscopic management instead of radical nephroureterectomy? It's because we do have studies that show that in properly selected patients, specifically low-grade patients, that endoscopic management and nephroureterectomy had similar oncological outcomes for low-grade non-invasive disease. This is 5 and 10 years. And let's look at the guidelines. So tumor ablation should be initial management for patients with low risk, favorable upper tract urothelial carcinoma. And it should be offered as the initial management to these patients, and also with select patients with high risk, favorable disease who have low volume tumors or cannot undergo radical nephroureterectomy.